عليكم السلام ورحمة الله.
وعليكم السلام ورحمة.
وعليكم السلام.
Okay, guys, inshallah, today, inshallah, we will continue for trauma, but this time non-major trauma. What about the discussion for previous recalls, guys? Is it helpful?
Yes, very helpful.
Okay, inshallah, also we will start posting the questions. Just give me time. I will do my best, inshallah. You will have two recalls. You will have also new channel which will be very helpful. Okay. And inshallah, I'm trying to do my best to be dependent on the channel only. Okay. So I will collect all questions from many sources and the most important, most expected questions. So it will cover every point. Okay. Inshallah, it will be dependent. Okay. But what I need from you guys, I want to make one session for per week. So give me chance to finish recalls and also to finish question bank. The priority for question bank. I think you agree with me. Okay. So here non-major trauma, it means we are talking about shoulder, arm, elbow, forearm, wrist, hand, also lower body, so hip, thigh, knee, leg, ankle, foot. So if you will go one by one, what are the major trauma, guys?
Head injury, spinal, chest, abdominal, major pain.
Yes. So in major trauma, it means head injury, maybe plus or minus maxillofacial injury, a spinal injury also after the head, and chest injury, abdomen, and if the Royal College say abdomen, it means abdomen and pelvis. Major bear. So here regarding guidelines for spinal injury, different if it will be the spinal and head injury. Take care. I sent already in the group. You have two guidelines. One guideline for spinal injury, the patient has mentioned in the scenario neck injury only. They did not mention head injury. So you have to follow the guidelines. And also you have different guidelines if the patient has neck injury with head injury. Is that clear for you guys? I sent in the group.
Yes, doc.
Yeah. So in the scenario in the exam, check this patient neck injury only or neck injury with head injury. Okay. So we will go back for non-major trauma. Today we will discuss about shoulder, arm, elbow, forearm, wrist, and hand. So upper limb. And next time, inshallah, we will discuss lower limb with wound management and bites. So bites here may be human bite or animal bite, or and animal bites here it involve also rabies. So we will talk also next time about a snake bite. These topics very important for the examiner, for the Royal College. So inshallah we will discuss them next time. So we will focus today on the upper limb. And here the expected questions. They will ask you about reduction, about mechanism of injury, about finding, about diagnosis, about management, and also they will ask you about disposition, decision making. So disposition here, it's confusing. You will discharge the patient, or you will observe the patient, or you will make back slap, or you will refer to orthopedic, or what. So decision making here always confusing. It's not about treatment. The Royal College, they know that you are familiar with the management or the treatment. So they are testing your skills in decision making. Okay. So we will discuss every point, inshallah. And anything which not covered in sessions, whatever in old decision or new sessions, it will be covered in the question bank channel, inshallah. We will not leave any corner for the Royal College. Okay, we will start by the first one, shoulder. So from up to down, shoulder here. How many muscles in shoulder, guys?
4.
Yes, 4 muscles. So we are talking about rotator cuff muscle. So rotator cuff here means we are talking about 4 muscles. Okay. So if the patient has injury or problem in one muscle, you will mention the name of the muscle. Okay. This will help you. The voice is clear, guys, or interrupted?
Clear.
Clear.
Yes.
Okay. So here regarding this topic, shoulder problem. So it will help you in intermediate SBA, it will help you in MRChem OSCE, it will help you in FRChem SBA and FRChem OSCE as well. So here, any problem in one muscle, you will mention the name of the muscle. If problem in all muscles, so what is the problem here?
Rotator cuff injury.
Rotator cuff problem. Okay. So here, supraspinatus, this is the anterior view, and this is the posterior view. So it's a superior or inferior supraspinatus?
Superior, the most superior.
Yes, excellent. So this one will be responsible for abduction, will initiate abduction. Okay. And here, 2 muscles, infraspinatus and teres minor. Infraspinatus. So we started from up to down. So first one, supraspinatus. Second one, infraspinatus and teres minor. It's like one muscle, right?
Yes.
Both of them like one muscle. That's why I want you to memorize both of them together. If the patient has problem in infraspinatus, you can say infraspinatus and
Teres minor.
teres minor. Okay. The last one, subscapularis. Okay. Subscapularis. This one will be in the anterior view. So here you have 4 muscles, supraspinatus. So one test, infraspinatus and teres minor. It's a second test. After that, subscapularis, third test. 1 second, guys. Okay, so how many tests, guys?
3 tests.
3 tests. Okay, so here first we will start by supraspinatus. After that, infraspinatus and subscapularis. After that, teres minor. Okay, so we have also bones and ligaments. Bones and ligaments and joints. Bones, ligaments, joints. So here you have the clavicle and also here scapula. So the scapula here acromion and the coracoid process. So You have ligament here between the clavicle and the acromion. You have ligament between the coracoid process and acromion. So it's from the name coracoid, it's coracoacromial. So between coracoid and acromion. So here, acromioclavicular joint also, acromioclavicular joint. So this one, this ligament, what is the name?
Acromioclavicular.
Is from the name acromioclavicular. So any patient has pathology here, so they can ask you in this ligament. It's very helpful in both in all exams. If you understand this session today, it will help you in all exams, inshallah. Okay. And this station or this shoulder examination, very common in the next exam, MRChem ask. Okay. So here we have 3 problems in muscles, 3 problems in muscles, and 3 tests. In the exam, they can ask you in each test. So the test for supraspinatus and infraspinatus teres minor and teres major, it's not included. Take care. Okay. So after that, the ligament acromioclavicular. This is the one important here. So acromioclavicular joint pathology. Okay. So here regarding acromioclavicular joint pathology, you have 5 grades, 6 grades. Okay, you have 6 grades. This ligament, this one. Okay. Always when you study anything, check the severity first. Okay. If you understand the severity, it will be helpful because you are emergent. So we will go from down. Severity, it means we will go from down. 6. And this is one rare. So rupture, acromioclavicular ligament, joint capsule, coracoclavicular ligament also. Okay. The clavicle displaced behind the tendons of biceps and the coracobrachialis. Okay. We will see the grade 5, rupture of acromioclavicular ligament. This one. Joint capsule, coracoclavicular ligaments. Coracoclavicular ligaments. So both ligaments injured in both grades. Okay. Elevated clavicle. Elevated clavicle. Okay. Detachment of deltoid and trapezius. Coracoclavicular distance more than twice normal on X-ray. So I need from you just remember number 5 and 6. Okay. So here, if you find both ligaments injured, so this grade 5 or 6?
Both.
5.
Both. Okay. So if you find the clavicle behind, okay, behind tendons of biceps and the coracobrachialis, so it's a grade.
Grade 6.
Yes. If you find the clavicle elevated,
5.
so it's a 5. And here the distance, coracoclavicular distance, coracoclavicular. So this one, coracoclavicular, this one. Okay. So distance how much? More than twice normal.
أيوة.
Okay. Because clavicle is elevated, right?
Yes.
Can you imagine if clavicle elevated, it means the distance will be more than 2-fold. Okay. So again, here you have 3 diagnoses. I'm talking about what?
Rotator cuff injury.
Yes. So I'm talking about the muscle now, not the bone, not the joint, not the ligament. I'm talking about the muscles. Okay. So if the patient has problem in rotator cuff injury, it means a problem in all muscles. So maybe tendonitis in the tendon only, inflammation in the tendon only, maybe impingement, the patient has pain on movement, or tear. If the patient has tear, it means he has weakness, right? Okay. So what is the difference between 3? Tendonitis, it means the patient is not moving, but has tenderness when you are putting your finger on the shoulder. Okay, how to know the patient has tenderness, guys?
By palpation.
Yes,
Palpating
palpitation, but
or
not
active.
if you are looking
Looking
at his eyes.
Yeah.
If you are looking at his eyes, right?
Mm.
In any examination in ER, any examination in ER or in OSCE, inshallah, I wish all of you guys you pass, inshallah. So in any examination, your eyes on the eyes of the patient and verbalize to the examiner, I am checking for tenderness, looking at the eyes of the patient. This is how to verbalize, how to get marks in OSCE also. Okay, so tendonitis here, the patient is just standing and you are the one palpating, feeling by your hand and looking at his eyes. If he has discomfort, facial discomfort, it means he has tenderness. It means tendonitis. But impingement here, if you ask the patient to move his shoulder, he has pain. So what does it mean, pain on movement?
Impingement syndrome.
Impingement. Okay. But the patient can move. He has no weakness. Okay. He has only pain. If the patient
So
has,
in impingement, there is no pain unless he moves the limb.
yes, yes. Regarding tear, so tear here, it means a weakness. So if the patient has weakness and he can elevate his shoulder or do abduction, so it's only weakness. If the patient cannot move his shoulder at all, it's a weakness, partial tear or complete tear.
Complete.
Here.
Complete tear.
Complete here.
Logic?
Yes.
Yes. Okay. So here regarding supraspinatus and the deltoid, both of them can cause abduction. But what is the principal muscle?
Supraspinatus.
Supraspinatus. Internal rotator.
Subscapularis.
External rotator.
Infraspinatus and clonus minor.
Always these
Together.
muscles together, right?
Yes.
Okay. So regarding abduction and rotation, so remember that. What do you need from shoulder examination? Abduction and rotation. Okay. What is the most important examination in the exam? Shoulder, elbow, and knee. What is the most important of them? Shoulder and knee. They can ask you in examination how to do examination, and in OSCE also, both of them very, very important. Okay. So here we finished this one already. Okay. So regarding supraspinatus, you have 3 tests. They can ask you in the exam. Supraspinatus, you have 3 tests. Near's test, Jobs test, or Emetican test. We will describe everything. It will be easy in the end. And the drop test. How many tests for supraspinatus?
3 tests.
Near's test, Jobs test, drop test. Okay. Or you can say Emetican test for Jobs test. Drop test, it means you can ask the patient to move his arm. After that, ask him to slow down. So if drop, it means positive. Okay, we will discuss that. Okay, so it's called painful arc, or all of them, it's for impingement or tear. So these are special tests. These are special tests. So all of them for what? Impingement or
And tear.
If the patient has pain on movement, it means impingement. If the patient has weakness, it means tear. Okay. Subscapularis, so this one internal rotator. So you can ask him for Gerber lift-off test. Okay. So he will put his arm back and you will check if he has pain or he has weakness. Don't worry. You will understand when we show the slide with pictures in it. Just understand this one 3 tests, this one 1 test, 1 test. Okay. Infraspinatus and the teres minor together, so it's called raised external resistance external rotation test. Acromioclavicular joint is brain. Acromioclavicular joint is brain. So here regarding this one, acromioclavicular joint. How you understand this patient has tenderness here, has pathology here. How you understand, guys?
Tenderness in palpation.
Yes, tenderness in palpation. What else? Grade 4 or grade 5. What about clavicle? In place or displaced?
Displaced elevated.
Displaced.
Displaced.
When you feel that by your hand, you will feel what?
And displaced clavicle.
What is called the displaced? What is called the impalpation? Step deformity, right? When you go with clavicle from here, it's a normal. Suddenly, your hand will be down. It's called step deformity. Like you are going from stairs, from up to down, right? It's called step deformity. Okay. Okay, and also a scarf test. So just understand the name of the muscle and the name of the test and how to do the test. We will show you, it will be very easy for you. And again, it will help you in prescription. Okay, so 3 tests, 1 test, 1 test, 1 test. Okay, these are the most common pathologies in the exam, whatever SPA or OSCE. Okay, in examination, if they ask you, even you are not familiar with examination, just remember that. Look, feel, move, special test. How many tests, guys?
4.
Look by your eyes. Don't touch the patient. Okay? Feel, it means touch the patient. And they look for his what? And feel?
His eye. His eye.
Eyes. Okay.
Patient is
For discomfort, for tenderness.
pain.
Okay. And feel also for temperature. The part you touch, check for temperature. And the temperature here, check both sides. If you are examining hand, check temperature both sides together. If you are checking shoulder, check both shoulder together. Move. So move here, you ask the patient to move, and then you can move for him. If you ask the patient to move for himself, what does it mean? Active or passive movement?
Passive.
Passive.
Active.
Active. It's active.
If the patient is doing activity, it means active. If the patient is not doing activity and you are making for him, it means passive, right?
Mm-hmm.
Yeah, okay. And the special test, okay? So special test, what does it mean? This test, right?
Yeah.
Okay. So we will go for look. So this is slide for look. So you will, in examination in the exam or in practice in real life, so look from in front, from side, from back, from, so 3 times, okay? Here in front, you will look for what? Head and neck, posture, alignment. You will look for symmetry of shoulders, both shoulders, in the same level or not. You will check for deltoid wasting, okay? You will check for alignment for shoulder girdle. You will check for scars. Remember that in any examination, not only the shoulders, okay? And from sides for scars. They will not ask you in the exam regarding this point. Just remember, look, okay? Inspect from behind for scars. Also, you have 2 muscles from behind, deltoid and trapezius. Okay? And back here, ask the patient to put his arms on the wall. This test for what?
Subscapularis.
Thinking.
For wing
Yeah.
scapula.
Long thoracic nerve.
Yes, excellent. For wing scapula. Okay. Long thoracic nerve or what else?
I think
From
subscapularis tear.
Okay, so this test for winging of scapula. Winging of scapula, you have medial and lateral winging. I will send this picture in the group, inshallah, after the session. Okay, so winging of scapula here, it
Rhomboid.
medial and lateral. Medial, it means long thoracic nerve injury and serratus anterior muscle, right?
Yes.
Yeah. Lateral winging, I will send you in the group, inshallah. Okay, we finished look. So we will go for what?
Feel.
Feel by your hand, right? And looking at
Patient eyes.
Eyes for tenderness.
for tenderness. Don't say for pain, for tenderness. Okay. So first of all, you will check for temperature, both sides. So check for temperature for what, guys? This joint for what?
Sign of inflammation.
Excellent, for inflammation. Excellent.
Signs of inflammation.
Yes. So for septic arthritis, right? If the patient has a problem in left shoulder and he has high temperature, it's hard to touch compared with the other shoulder. So what does arthritis? Okay. After that, you will check for bones and tendons. Okay. So palpate shoulder girdle. You will start by sternoclavicular joint. Sterno means sternum and the clavicle, the junction between sternum and the clavicle. After that, you will go for clavicle. After that, acromioclavicular joint. What is the most important for us here?
Acromioclavicular joint.
Acromioclavicular.
Acromioclavicular.
So once you touch this one and he has tenderness, what is the problem? Acromioclavicular joint pathology.
Is it tendon?
Okay. And if
Yes.
the clavicle elevated, so it's a grade.
5.
Right.
If the clavicle behind the tendons, it's a grade.
6.
Excellent. And you can continue coracoid process, head of humerus, greater tuberosity of humerus. After that, palpate border of spine. Okay. So if the patient has tenderness here, for example, in any part, so it's called
Tendinitis.
tendonitis. Excellent. So is the patient moving?
Impingement.
Is the no? I'm talking now. Is the patient moving?
No.
No.
So if the patient not moving and on palpation he has tenderness, it means tendonitis. If he has tenderness on acromioclavicular joint, what does it mean?
Acromioclavicular tear.
Sprain.
Pathology.
Pathology.
Okay. We don't know now, is it tear or dislocation or what, right?
Yes. Okay.
Okay. So after that, after feel, move. So move here, it means active and
Passive.
Passive.
yes. Which one is first?
Active. The
Active.
patient moves his
Active.
limb.
Maybe he cannot move his joint, right? So
Yes.
ask him to move first. After that, if he cannot move, you can move for him, right?
Yes.
So you ask the patient to move his shoulder. In OSCE or in practice, how to do that, guys, to save time in the exam in OSCE. So you can do the action and ask him to do that. So can you do like that? He will do. So it will save your time in OSCE, inshallah. So here, internal rotation. So shoulder abduction and the external rotation and the shoulder internal rotation. Okay. So can you do like that? It will be shoulder abduction and the external rotation. Okay. And this one, can you do like that? It will be shoulder internal rotation. Okay. So after that, you ask him to do this action. What is the action here, guys?
Flexion of the shoulder.
Yes, flexion. What is the action here?
Shoulder
Extension.
extension.
Detention. This action?
Abduction.
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 This action?
External
External
rotation.
rotation.
how to know external or internal rotation? So this is the midline, right? If away from midline, what does it mean?
External rotation.
Yes, if close to the midline.
Internal rotation.
Okay, excellent. So if the patient,
Internal.
what is the principal abduction?
Supraspinatus.
Supraspinatus.
Okay, so
The area 0 to 15.
yes, abduction.
15 centimeters. The rest deltoid.
If the patient is doing abduction, it means supraspinatus is okay, and also regarding deltoid also is okay. Regarding if the patient,
Excuse me, doc. The supraspinatus just initiate the abduction up to 15 degrees, as I see.
yes,
And the rest of the abduction done by deltoid.
yes,
That
okay. So here, what is the principal external rotation?
Infraspinatus and
Infraspinatus.
Excellent. Infraspinatus and the teres minor. Excellent. And what is the principal rotation?
subscapularis.
Okay, excellent. After that, you can feel the scapular movement. Okay. The important for us, this test for abduction movement, and this test for external rotation, and this test for internal rotation. How many in movement test?
Three.
For 4 muscles. 1 muscle, 2 muscles, and 1 muscle. Okay. After that, you can do what?
Passive.
Passive.
Means you ask the patient and you will do for him. So in OSCE or in practice, please relax and I will do the same for you. Abduction, flexion, after that extension, abduction, external rotation, and internal rotation. So if away from the midline, what is called?
External.
Close to the midline.
Internal rotation.
Okay.
External rotation.
If we finish look, feel, move. What after
test.
feel, move?
Special test.
Fix that in all examination. And believe me, guys, it's very interesting. If you are familiar now with shoulder examination and you are doing with patient with shoulder pain, believe me, very interesting in real practice, right? Okay. So here, how many tests for supraspinatus?
3 tests.
3 tests. Okay. So first of all, near the test. After that, MT can test.
3 tests.
MT can test. So it's like the patient holding cans, can Pepsi, and he is doing what? Emitting. Clear?
Emptying the can.
Emitting the can. Clear? Okay. This one also the same, like emitting the can. Okay. So the same of direction of the arm, but here the action it's different. So here you will rotate his neck, his arm. It will be external rotation. Okay. So here, if the patient has pain, what does it mean?
Tendinitis.
It means supraspinatus, right? So any positive test in these 3 tests related to which muscle?
Supraspinatus.
Whatever impingement or weakness. If the patient has tenderness in his eyes, what does it mean?
Tendinitis.
No,
Tendinitis.
in feeling. We finished feeling already, right? Tendonitis only in feeling. So look, feel, move, and
Impingement.
a special test. Okay, so a special test here, it will show you impingement or
Here.
tear. Clear?
Yes.
Okay, so any test you are doing, so ask the patient for
It's
resistance.
painful.
Ask him to resist you, and also look at his eyes. So you will rotate his arm and look at his eye. If the patient has resistance, good resistance, it's good. You are resisting the examiner or the doctor, it means the muscle is effective, right?
Yes.
Yes. Okay. If the patient has no resistance, it means weakness, right?
Yes.
Okay. So here you ask the patient to do like that, and you will do MTCAN test. So he's looking at the eyes of the patient, and also he's pushing the arm down. Okay. If the patient has tenderness, what does it mean in this test?
Supraspinal injury.
What type of injury here?
Most likely
Or
tear.
there only? He has good resistance. He can resist the examiner.
Impingement.
Benjamin, excellent. If the patient cannot resist, it's going down easily.
Tear.
It's weakness.
Yes. So supraspinatus what? Tear.
Tear.
Yeah.
Yes. Okay. So we finish this one near the test, and we finish this one MTCAN test. So both of
Excuse me, doc. In NIRS test,
yes.
just I show the examiner is going to put his hand under the arm.
Yes.
How is going to resist
Rotating.
the patient abduction? This is for rotation or for abduction? And we are putting in mind that we are examining the supraspinatus, and we know that supraspinatus functioning is just the abduction.
Yes.
It is very clear for me for the MTCAN test. It's
Yes.
very clear.
Yes.
In the MTCAN test, they are testing for supraspinatus by resisting the abduction of the patient by the examiner.
Yes.
But in NIRS test, is not quite clear. Can you explain it again, please? Thank you.
Yes, excellent. So here, as supraspinatus, it's for abduction, and you are asking the patient to do abduction, and you are pushing him down, right? This is your point.
Yes.
This
But
one,
if I ask him to do abduction, I have to push him down just like in MTCAN. But for the NIRS test, it's not that clear like MTCAN test.
Yes.
MTCAN test for me is quite clear.
yes.
But for the NIRS, I just it's not clear. It's confusing.
So near the test here, you ask the patient to do abduction, and also you will do rotation. So rotation here, it will exacerbate the pain. Did you get my point?
It's okay. Okay. Thank you.
Do abduction, and you can rotate the arm, so it will exacerbate the pain. The patient.
Okay. Thank you.
Yeah. It means he has supraspinatus impingement. Excellent. Okay. The third one, what is called?
Drop test.
Drop test.
The drop test.
Yes. We are testing which muscle?
Supraspinatus.
Supraspinatus.
Ask him to do what? What is the function of supraspinatus?
Abduction.
Abduction.
We'll ask him.
Abduction.
Abduction. Excellent. So ask the patient to do abduction, and his arm touch his ears. So how many degrees?
90
degree.
180 degrees.
180 degrees.
Okay. So 90, it will be like that here, right? Okay. So if touching the ears, it means 180 degrees. Okay. So ask the patient to lower his arm. If his arm dropped, so it's a weakness or impingement?
Weakness.
Weakness.
Weakness. It means a tear, right? Which muscle?
Yes.
Supraspinatus.
Spinatus.
I think it's clear now, right?
Yes.
Okay. So if the patient can control his arm, he is lowering his arm slowly, but he has pain only. What does it mean? Supraspinatus what?
Impingement.
Excellent, excellent.
Impingement.
Okay. So if the patient has pain from degree 60 to 120, 60 to 120, so what does it call?
Painful arc.
Painful arc.
Painful arc. You can say painful arc or supraspinatus impingement. Clear? Okay. If the patient has pain on 180 degrees, so what is the problem here?
180 degrees.
100.
Deltoid.
No, acromioclavicular joint pathology.
Chronic-clavicular joint. Okay.
Okay. So if the patient, so I think MT can test, ask the patient can MT can test and check his eyes for tenderness and push down. Ask the patient to do abduction and push him down. It will be for spinatus impingement or tear. And here, if the patient has pain, impingement, so it's a supraspinatus. Ask him to do abduction and do rotation. Okay. And the rotation here is toward his ears, not away from his ears. Okay. And here, drop test. So ask him to do abduction, 180 degree, and he will lower. So if he has pain on 180 degree, what is the problem?
Acromioclavicular pathology.
Yes.
Acromioclavicular pathology.
If he has pain on 60 up to 120.
Painful arc.
Painful arc. Supraspinatus.
Impingement or painful arc. If the patient, his arm drops.
Is here in
Supraspinatus muscle.
We finished supraspinatus. How many tests for supraspinatus?
3 tests.
Three. Okay. We still have
3 tests.
or 3 tests. Okay. So,
Dr. Hani, one question.
yes. Yeah, sure. Ask, please.
Hello, yeah, Dr. Hani, now supraspinatus muscle actually it involves from 0 to 15. Yeah, supraspinatus muscle involves from 0 to 15 degrees, then takes off by the deltoid muscle for the rest of the movement. So when we are assessing the supraspinatus muscle, so we are also same time we are assessing the deltoid muscle as well. So is it an isolated test for supraspinatus muscle or both together?
No, this test only for supraspinatus all over the world.
Okay, so the nearest test is not, can you explain again, because the near test is a bit confusing to me actually.
You ask the patient to do abduction and you will do rotation. So rotation here, it means exacerbation.
Abduction, how much? How many degrees, doctor?
No, it's not about how many degrees. Just ask the patient to do abduction. Okay. So it's a better.
Okay. 90 degrees above.
Yes, it's a better for more than 90. Okay. Yeah, better to be more than 90. Both of them.
Okay, abduction and internal rotation.
Yeah. Okay.
Okay.
Yeah. So here, this test for what? You ask. You will ask the patient to do external rotation. It means away from headline. So it means you push inside, right?
Rotation.
Okay. Yes.
So
yes.
What are the methods for external rotation?
Infraspinatus and teres.
Yes, infraspinatus and teres minor. So what is the name of the test if they ask you in the exam?
Resisted external rotation.
External rotation.
The patient is doing external rotation, right? and against resistance. That's why it's called resisted external rotation test. Clear? Okay. So you will check his eyes for what?
Tenderness.
Tender.
And you will push, checking for what?
Muscle strength.
Muscle.
For weakness.
Resistance.
Okay. So your eyes checking his eyes and your hand checking resistance. Clear? Okay.
Yes.
So here, if the patient has only tenderness, what is the problem in this test?
Impingement.
Impingement.
What is impingement? Which muscle?
Infraspinatus and teres minor.
Teres minor.
Complete answers. You can say infraspinatus and teres minor impingement. Clear? Okay. The patient has no resistance. You are pushing him. His hand is going crossing the midline.
Infraspinatus
Weakness.
teres minor. Tear.
Weakness.
Excellent. Infraspinatus and teres minor weakness, tear. Okay. So this test, you ask the patient to do, what is the name of the test?
Gibber's lift off test.
Okay. So
Yeah.
lift off
Test.
means he will put his arm behind his back and you will push against his arm. And you are looking at his what?
His eyes.
Yes. So you will check eyes for tenderness and you will check hand for resistance. If the patient has only tenderness, which muscle here?
Subscapularis muscle.
Yes. So subscapularis what?
Impingement.
Impingement.
Okay, excellent. Okay. And if the patient has no weakness, sorry, if he has weakness,
Subscapularis tear. Weakness.
subscapularis tear. Excellent. Okay. So if the patient has acromioclavicular joint pathology, what to do?
Scarf.
Scarf test. If he doesn't have acromioclavicular joint, do you need to do scarf test?
No.
No.
No. So how to know acromioclavicular joint pathology? What is the degree?
Over 180 degrees.
180.
With 8, yeah.
And what else? In palpation, you remember? If you feel
Tenderness in acromioclavicular joint tenderness.
and the clavicle what?
Elevated.
Deform.
Elevated.
Step
Excellent.
down.
Deform deformity.
Excellent. Okay. So if you find tenderness in acromioclavicular joint and you find clavicle elevated and also you find the patient has pain in 180 degree, so you will go for which test?
Scarf
test.
So you will ask him to do in 90 degree abduction and also the elbow 90 degree to touch the other shoulder. You will push toward the other shoulder. If the patient exacerbating the pain, what does it mean?
Test positive.
Positive. What does it mean?
Clavicular joint pathology.
Okay, excellent. Okay. Okay. So here regarding the shoulder, you can expect which dislocation. How many dislocation in the shoulder?
2.
Anterior or posterior?
Yes, anterior and posterior. So they can ask you about the findings, they can ask you about the diagnosis, they can ask you about the management. So if you scenario, for example, the patient has seizures. Seizures here, it's common with anterior or posterior?
Posterior.
Posterior. So don't think only posterior. So you have to complete the scenario. You have to check also the X-ray may be different. Okay. So if they show you this X-ray, what is the
Anterior.
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 anterior or inferior?
Inferior.
Inferior.
Actually, no inferior in the exam. So
Anterior, yes.
yeah. So
Anterior.
think only about anterior or posterior. If the examiner give you interior, it means they have nothing to do. So the most common anterior and posterior. So here it's a loss of congruity between humeral head and the glenoid. So it's not matching. This head should be here. So congruity here lost. Okay. And also in any examination in joint, so you will do neurovascular assessment how many times?
Two time.
Yes.
Two times.
And
Before and after reduction.
After the
yes, excellent. So regarding the fracture or dislocation, you have to do neurovascular assessment before and after. And what about X-ray?
also before and after.
Yes,
Before and
yes, excellent. Okay. And here the management, you have to do embolization and refer to orthopedic. Okay. You have indication to refer to orthopedic and you have indication to discharge. So any dislocation associated with fracture, you will discharge or refer.
We will refer.
Here.
So if the patient has only dislocation without fracture, so you can reduce and do backslap. I'll ask you also about the injuries. Be familiar with injuries. So here in shoulder, you can get axillary artery or nerve or brachial plexus. And also you can expect they ask you in the exam regarding the technique. So they will ask you in the most common techniques, how to do that. So external rotation, from the name external rotation, you do external rotation to the patient. After that, abduction. After that, the opposite, internal rotation and adduction. And also modified mesh method. Here regarding this X-ray, what do you think?
Posterior.
Shoulder.
Posterior.
Light bulb sign.
Light bulb sign.
Yes, excellent. If you find the X-ray, it's not anterior, so for sure it's a posterior, right? Okay. And also widening here of the space other than bulb sign. Okay. So here it will be widening of glenohumeral gap and the light bulb sign. Okay. So mechanism of injury also, they can ask you whatever anterior or posterior, be familiar with that. They can ask you in the exam. So axial loading of abducted and internal rotated arm, low to the anterior portion of shoulder. Here the injury will be the same, whatever posterior or anterior. So the most important injuries, artery or nerve or muscle or what?
Artery. Axillary artery.
Because artery can cause ischemia, can cause gangrene. Okay, so here, what is the single most likely diagnosis?
Anterior.
This is anterior shoulder dislocation.
Yes. So here regarding the complication, regarding the bones, they can ask you in the bones also. Okay. So okay. So anterior shoulder dislocation is the most type of shoulder dislocation. Also, they can ask you in such questions. So, for example, which is most common? So you can choose anterior. So any word is they can ask you in the exam like that. Okay. So here, the mechanism of injury, direct blow or fall onto outstretched hand. They can ask you about the mechanism of injury. Okay. The most common injured nerve, if they ask you about nerve, answer nerve. So what is the most common nerve?
Axillary nerve.
Axillary nerve.
Yes.
Axillary nerve.
What about the management?
Reduction.
Reduction.
Rotation or modified.
Manipulation and
Manipulation and the reduction, following by
immobilization.
Immobilization in a broad arm split. Sleep.
So be familiar with each point. So they can give you the X-ray, they can give you scenario, and they will say patient management is done, manipulation and reduction. What is the next action? Discharge or repair or immobilization in broad arm sling? What do you think?
Mobilization. In a broad arm sling.
Yes, so when you are studying, each point can be question. Take care. Okay, what is the, which of the following is not suitable method not to treat this injury? What do you think, guys? What is the
Absolutely.
dislocation here?
Anterior.
Anterior. Sir.
There you, so you have to be familiar with names of techniques, at least names.
Sapso.
Milch Cohes, yes.
Okay, so it's a Alice maneuver. This one not included in techniques. Okay, so be familiar with these names, please. Okay, Kocher, Milch, Hippocrates, Stimson, Maston, Schemo, Manus. Do you find the Alice here?
No.
So this one for what?
Hip dislocation.
What is the diagnosis?
Posterior.
Posterior.
Yes, posterior. What is the sign?
Big bulb sign.
Okay. So here in posterior dislocation, it's only 5%. Okay. So X-ray features, absence of other than X-ray feature. So you can confirm the diagnosis by absence of external rotation. It can be another question. Okay. So for example, any joint, you can expect they will ask you in examination. So what does it mean, absence of external rotation, guys?
That infraspinatus
Rotated calf injury.
injury, mainly infraspinatus minor affected.
Here, the patient has injury or because of dislocation, these muscles not working.
Maybe because of the dislocation, this muscle not working.
Dislocation. How to understand these muscles working or not? You have to reduce first, right?
Yes.
Yes.
Yes. After reduction, you can test which muscles, infraspinatus and minor. Yes.
Yes.
Yes. Okay. So also O-line sign, so vertical dense line in the medial humeral head, and rim sign. Be familiar with that. They can ask you also in the exam. Okay. So number of associated injuries. So in anterior, it will be heel sac lesion, Bunkert lesion, but in posterior, reverse, right? Reverse heel sac lesion, reverse Bunkert lesion. Okay. So if they ask you what are the most important injuries in bones, what do you mean?
Reverse hill sac.
Reverse hill sac lesion. Reverse band.
Reverse band.
Acceleration bank.
So here, this curve, okay, should be continued, right? This curve continued or not?
No.
Discontinuous.
You have depression here, right?
Yes.
So
Yes.
this depression is called,
Bankart.
Bankart.
okay, you have bone here fractured, right?
Bankart.
Yes.
What does it mean? What is the single most likely diagnosis here?
Bankart lesion.
26 present with deformed painful left shoulder following tackle made playing rugby. Shoulder X-ray shown below. So here,
Fibrosity fracture.
okay. So this one Bunkert lesion. Okay. Okay. So This one, Bankart lesion, can you see? And Hill-Sachs lesion. Okay. So why we did not choose Hill-Sachs lesion?
No option.
Because it's no
It's
option.
not mentioned.
Not
No
many.
option.
Yes. So for example, in the exam, don't be scripted. For example, in asthma, what is the first line in asthma?
Salbutamol.
No.
Oxygen.
Excellent, oxygen. First line in asthma, high flow oxygen. So if they did high flow oxygen in the option, what is the next action?
Salbutamol.
Salbutamol.
Salbutamol. So for example, in airway management, the first action, plan A. But they did not give you plan A. They give you only plan B, C, D. What is the next step?
B.
B. So in real practice like that, guys, if the examiner giving you options, it means he is giving you resources. He is giving you equipment. Each hospital, you have resources. It means you have to choose from resources. For example, in asthma, patient asthmatic, and you ask the nurse, give oxygen. She said, the cylinder of oxygen is empty now. What to do next, guys?
Salbutamol.
Salbutamol.
Mobilization.
Is that clear?
Mhm.
So if the examiner giving you some options, it means this can happen in practice. You ask the nurse to give you video laryngoscope. She said it's not working. So the examiner can remove this option from the exam. Is that clear? He's testing your skills, how to deal with situation. Okay. So be familiar. This one Hill-Sachs lesion, and this one Bankart lesion. Yes. Okay. So what is the single most likely diagnosis?
Hill-Sachs.
Exactly.
Why not choose Bankart?
It's not available
Not
in
an
the
option.
options. Not in the options.
Okay, excellent. So we will choose Hill-Sachs lesion. Okay. So here they ask you about the injury. What is the diagnosis here?
Posterior dislocation.
The posterior dislocation.
Can you read his shoulder what?
Manipulated.
Manipulated means normal, right?
Yeah.
And the
Oh.
post-reduction X-ray is requested. It means X-ray before and
After.
this is one.
Post.
Okay. So
Post reduction.
yeah, post-reduction. So what is the injury expected here?
Rotator cuff.
Rotator cuff.
Recurrent
shoulder dislocation.
Yes, why? Which lesion?
Hill-Sachs.
Because of
Hill-Sachs.
Hill-Sachs lesion. This
Hill-Sachs.
lesion can cause
Recurrent shoulder.
Recurrent shoulder dislocation.
yes, excellent. Okay,
Doctor, what is this lesion? Sorry.
Hill-Sachs lesion.
Hill-Sachs. Oh, okay. Thank you.
So the above one, depression here. This curve should be continued, right?
Mhm.
This depression, it means Hill-Sachs lesion, and because of this lesion, he can get recurrent dislocation, and this lesion, Bankart. The above, Hill-Sachs. Okay.
Excuse me, Doc. Hill-Sachs, one of the associated pathology with the anterior
With anterior.
shoulder dislocation,
Yes.
and reverse with posterior.
Yes. If you will say
How what do you mean by reverse? Sorry.
yes, actually it's not available in the slide now, the picture, but I will send in the group.
Okay, thank you, Doc.
Okay. So here regarding the expected complication, so recurrent shoulder dislocation. Okay. here 25 man present with anterior. You plan to manipulate and reduce. Which single method not be suitable choice? Do you remember
Big-
Kocher, Eskimo, Hippocratic?
Bigelow?
Yes.
Glue.
So at least if you read the techniques many times, it will be familiar with your ear. Again, okay. So this one for hip dislocation. 18, dislocated right shoulder, successful reduction, referred to orthopedic outpatient for follow-up. So here, what is the most important position for him to avoid? It means already you ask him to do arm sling and refer him for clinic. Okay. So this patient, what advice? Avoid what?
Avoid
Yeah.
90 and palm up يعني.
Palm down.
Avoid. He's asking to avoid. Okay. So it means it's wrong. So arm here at degree to side with palm up. Avoid this one. Okay. So immediately after reducing shoulder dislocation, the arm should be placed in ball sling or similar type sling. This will keep the shoulder comfortable in safe position. And it will be maximum how many weeks?
2 weeks.
It can be different question. How many weeks? 2 weeks. In the first couple of weeks following the injury, risk of redislocation is the highest, and positions that could cause redislocation should be avoided. So what is the position to be avoided? Arm being held in 90 degree to side and palm facing upward. Why guys? Why to avoid this one? Risk of what?
Risk of redislocation.
Redislocation.
Yes, excellent. So if the patient putting his arm in this position, it means risk of redislocation. 21, anterior shoulder dislocation, fall from bush pipe, single nerve structure,
Axillary.
Axillary nerve.
axillary, yes. Okay. 30 years, fall directly onto his right shoulder, pain localized to his right acromioclavicular joint. So he's talking about what?
Acromioclavicular.
joint.
Okay. How many grades?
6.
6.
Okay. On examination, how to examine acromioclavicular?
Scarf.
180 degrees.
Palpation and test.
Excellent. Palpation first for tenderness. Okay. And after that, you will see the clavicle elevated or behind. Okay. And after that, you will see the distance in X-ray this later. Okay. So here regarding the test, special test, scarf test. Okay. He has tenderness over acromioclavicular joint. What does it mean?
Inflammation.
And
So
And,
acromioclavicular joint pathology. Okay. And the prominent step deformity can be felt. What does it mean, step deformity?
Displacement of the clavicle.
Clavicle displaced. X-ray of shoulder show marked superior elevation in X-ray, okay, of the clavicle with crococlavicular distance more than twice normal. Which grade this one?
5.
Five.
Grade 5.
Yes. No fracture is present. No fracture is present. What does it mean? No fracture is present.
Not grade 6.
It means it's a confirming joint pathology, right?
Yes. Yes.
So not the bone, the joint, right?
Yeah.
Okay. So which structure have ruptured in this case?
Answer.
Which one, guys?
First one.
Number one.
Okay. So acromioclavicular ligament, coracoclavicular ligament, and the joint capsule. So be familiar with grades. You can read this slide later, guys. Okay. So be familiar also with the management. Grade 1 to 3 injuries. Grade 1 to 3 injuries are usually treated what?
Conservative.
Conservative. So if they give you
Conservative.
the exam grade 1 or 2 or 3 and ask you what is the next step, conservative treatment. Okay. And if you find the option
Conservative management.
exam, ice, analgesia, shoulder, rest in sling. Okay. What about 4, 5?
6.
Require what?
Surgical
Surgical
fix.
Internal fixation.
Excellent. Surgical internal fixation. Excellent. 46-year-old elder suffers injury to his shoulder, complaining of pain and stiffness, interfering with his ability to walk. On examination, you note that he is unable to medially rotate. Medially rotate, what does it mean?
Internal.
Internal rotation.
Okay. Okay. What
Internal rotation.
what are the muscles for medial rotation?
Subscapulars.
Subscapularis.
Scapulary.
Okay. Clear now?
Yes.
Yes.
Very clear.
Ultrasound scan is performed, which confirm the presence of rotator cuff tear. So tear here, why he said tear?
He's unable. Not
Yes,
only pain.
unable. He is
There is weakness.
unable to medial rotate.
Yes.
No pain.
If the patient has pain and unable to move, it's a tear. If the patient has pain only, it's an impingement. Clear?
Yes.
Yeah. So if the patient has pain and he cannot move, it means also he has tear. But if he has pain only, it means
Impingement.
okay. So the 4 rotator cuff muscles, supraspinatus, subscapularis, infraspinatus, and teres major, always join together, infra and the teres major, both as one muscle. Okay. Okay. Supraspinatus assists deltoid to abduct the arm at the shoulder joint. The main abductor during first 15 degrees. Point 15, deltoid become principal abductor. Infraspinatus, as we said, the external or lateral rotator. So lateral, it means external. Medial, it means internal. Okay.
Yeah.
Yeah. 32, injury to his left shoulder. He now complains of pain. I want you guys, once you see, for example, shoulder in the exam, expect he is talking about examination, he is talking about test, he is talking about injury, he is talking about which shoulder, anterior or posterior. Clear? This is how to prepare yourself. And once you are in the exam, you found the word, so expect questions quickly. Okay? Complaints of
Can we expect that he asking about the nerves? Nerve
yes.
supply of that.
When you are studying, you have to expect questions. Ask yourself, what are the expected here? Okay. He now complains of pain when lifting his arm. Okay. What does it mean when he lifts?
Abduction.
Abduction.
On examination, he has limited abduction. He is confirming now. What does it mean, abduction? Which muscle?
Supraspinatus.
Supraspinatus.
Excellent. Please, guys, make mute. Okay. If you want to answer, you can make unmute. Here, the patient limited. Limited here, it means impingement or tear.
Tear.
Tear here.
Your consultant examines the patient and asks the patient to raise the arm parallel to the ground, okay, in the scapular plane, when rotating the arm internally with the thumb down. Which test is this one?
Empty can test.
Empty can test.
Excellent. He cannot maintain the position with his left arm when pressure is applied. What does it mean when pressure is applied?
Resistance.
Against resistance.
Against
With-
resistance. Excellent. You are pushing down. Okay. So he cannot maintain this one. What is the problem here?
Supraspinatus.
Yes.
Muscle.
Supraspinatus impingement or tear?
Tear.
Yeah.
Tear.
Excellent. Okay. 46 builder suffers injury to his shoulder, complaining of pain, stiffness, and interfering with ability to work, cannot abduct the arm, particular start range of motion. Ultrasound scan is performed, confirm the presence of rotator cuff. Which of the following muscle is most likely to be torn?
Supraspinatus.
So we finished already the shoulder. Any problem with shoulder? Okay.
No problem.
So we will go for elbow. Here, elbow, you have many dislocation, but what is the most important? What is the most common in the exam? Posterior or anterior or lateral or what, guys?
Posterior shoulder.
Posterior.
Posterior dislocation.
So how to know posterior or anterior? The proximal part or the distal part?
Distal part.
Distal. Okay. So check the distal. If you want to understand elbow or knee or whatever, anterior or posterior, check the distal part. You find distal part posterior, what does it mean?
Posterior dislocation.
Distal part is anterior.
Anterior.
Anterior dislocation.
Okay. So also, like any joint, so they can ask you about the examination, about the reduction, how to reduce, how to examine, and also the injury. So the injury here, be familiar with the artery, with the nerve. Okay. So posterior elbow dislocation, this is the second most common major joint dislocation. Second, that's why it's a common, very common in the exam. Named based on anatomic location of olecranon relative to humerus, as we said, check the distal part. Okay. Regarding posterolateral, it's not common in the exam. Okay, this one. They can ask you in the exam the mechanism of injury. So, what is the mechanism of injury?
Fall onto
stretched hand.
Yes. So, fall out stretched hand. In the exam, how to understand, or they can ask you. So, a swelling with obvious deformity. A swelling with obvious deformity. Elbow is flexed with prominent olecranon. Okay. Remember that in examination. So this one, look, feel, or move, or a special test. This one.
Inspection.
Feel.
Look. Okay. So swelling, obvious deformity. Elbow is flexed with prominent olecranon. Look here, it means an inspection. Okay. They can ask you about the associated injuries. So it can be fracture, medial or lateral epicondyle. Medial or lateral epicondyle. Remember that. After that, it can be radial head. After that, it can be coronoid process. So this regarding the fracture. What is the most common, guys?
Medial lateral
Medial or
epicondyle.
lateral epicondyle.
If they give you which of the following is most common fracture, medial, lateral, epicondyle, or radial head, or coronoid process, which one?
Medial.
Medial
Medial
lateral.
or lateral.
If they ask you epicondyle or radial head or coronoid process,
Epicondyle.
Epicondyle.
Medial.
okay. So neuropraxia also, it means which nerve here?
Anterior
Anterior
interosseous branch of median.
Yes, excellent. Anterior interosseous nerve, and this one, it's branch of median nerve. So they can ask you directly. For example, they will give you many nerves. So anterior interosseous nerve or ulnar nerve or radial nerve or whatever. And also they can give you axillary. So you can choose anterior interosseous nerve. They can ask you by different way. The patient cannot make A or K sign. Okay. So you can choose this one. They can ask you, the patient cannot, he will give you 5 options for signs. Okay. So you can choose this one. Remember that. Ligamentous surgery. What are the ligaments here, guys? Lateral collateral ligament. More
Collateral, medial.
yes, more than medial collateral ligament. Remember that. Okay. After that, brachial artery injury. So what is the artery in elbow?
Brachial.
Brachial artery.
Excellent.
Brachial artery.
Yes, excellent. Also, if you find the 3 fracture, what does it mean 3?
Triangle.
Terrible triangle.
Posterior
Three
dislocation,
triangle.
Find the
radial
3
head
fracture,
fracture,
it's called triple
dorsal
triangle.
fracture.
So if you find the posterior dislocation and the radial head fracture, so it means triple triad. Remember that. Okay, we finished that. So what about the management? The management, if you find the simple, what does it mean simple, guys? No fracture, right? Simple dislocation only. So what is the management here? Pain control.
Analgesic.
Pain control plus or minus procedure sedation and reduction.
And
Plus or minus.
like any joint, okay? What if the patient has fracture?
Involved orthopedics. Involved orthopedics.
Yes, because this patient maybe needs ORF, okay? Okay. After that is splint, posterior long arm. So in shoulder, what is the
Think.
Arm sling.
okay, so you can do cast and arm sling. Here splint, it will be posterior long arm. Okay. Also consider if complex. Regarding this position, if simple, you can discharge the patient with orthopedic follow-up. It means in clinic. Within how many weeks?
1 week.
1 week.
If complex, so orthopedic recommendation. Okay, 14 year. Can you imagine here an elbow, young age? Because it's common in less than 20. So posterolateral elbow dislocation. On X-ray, you note presence of associated fracture. Which fracture is most commonly associated with elbow dislocation?
Radial head.
Medial epicondyle.
Medial epicondyle.
Excellent. Middle epicondyle fracture. So here, regarding elbow dislocation, as we said,
Medial epicondyle.
it's second most major joint dislocation. And here they can ask you about the mechanism of injury also. Okay. Okay. So how to reduce? How to reduce? They can ask you in the exam. Okay. In previous format, SAQ, they can ask you in one technique. They can mention how to reduce. So it's up to you. But here in single best answer, do you think it's a logic to memorize only one, or you have to memorize two?
Two. Memorize too.
Yes, you have to memorize too. Why? Because they can ask you in the exam which of the following technique is appropriate to reduce this dislocation, right? So you have to be familiar with 1 and 2. Okay. So number 1, flex the elbow. Ask the patient to flex the elbow. How many degrees?
60.
60 degree.
Yes. So ask the patient to do flexion. Okay, 60 degree. After that, one doctor will catch which bone? This one?
Humerus.
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 Humerus. And the other doctor will catch?
Forearm.
Radius ulna.
Yes. And
The forearm bones.
so this one arm, this one forearm. Okay. So it will be action, traction, and the counter traction. This one will do traction, and this one what?
Counter traction.
Counter traction.
Yes. Okay. This one technique. Okay. The second technique. Can you imagine if you push this olecranon, it will be reduced, right?
Yes.
If you will push this bone, okay, it will be reduced. Okay. So the first one, flex the elbow 60 degree. One doctor will do traction here. It's a forearm or forearm.
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 Any, no problem. The most important, you can do traction in arm or forearm, and the other doctor will do counter traction for the other one. Clear?
Yes.
It means one will do traction and the other one counter traction. It means do traction against. Okay. Okay. And here, pull on the fully pronated forearm. It means you ask the patient to do flexion for the elbow 60 degree and the forearm what?
Pronated.
Fully pronated. Okay. Yes. The second technique, lever the olecranon forward with both thumbs. Okay. While holding the elbow flexed. Lever the olecranon forward with both thumbs while holding the elbow flexed. Assistant then provide traction on the forearm. Okay. 21, football player with deformed, severely painful elbow. So in the scenario, check shoulder or elbow or knee. Fall onto his right arm. What does it mean, fall onto his right arm?
Outstretched.
Outstretched.
Yes, so most likely dislocation. Okay, X-ray is performed, which is shown below. I forgot to put the X-ray. Anyway, it will be posterior dislocation. So what is the most commonly damaged?
Anterior interosseous nerve. Anterior interosseous nerve.
Oops.
Medial epicondyle.
Okay, so this one posterior lateral dislocation. Okay, I did not put the X-ray. Okay, so it's a posterior lateral, not posterior. Okay. So here, neurovascular injuries, relatively uncommon, but thorough neurovascular examination should always be performed. The most commonly damaged structure is ulnar nerve due to valgus stretching. Median nerve can be also damaged, but this is less common. Damage to the brachial artery is rare. We are talking about which one, guys?
Posterior
lateral.
Posterior lateral. Okay.
So it's different than the posterior. So in the posterior, the most common is the anterior interosseous, and the posterior lateral is the ulnar.
Yes. Okay. So here, the most common associated fracture is complex dislocation of medial epicondyle. Okay. Regarding bald elbow in which age?
Children.
children.
toddler.
Right, freaking children.
Children here
Housemates.
up to 5
Housemates.
up to 5 years. So what is the problem? Which bone?
Radius.
Radius.
Radial head dislocation. Okay. So here, because of traction and no history of trauma, how to diagnose that in the exam? They will not mention trauma in the scenario. They will say
Supporting, on the other hand.
they are holding the baby and they are protecting him, for example, from the car. So it means it's a bald elbow. So here, which ligament?
Annular.
Annular.
Yes. So here is slipped annular ligament. 4 years. It means it's logic to be how to know it's fracture or it's also they have another name rather than bald elbow. Do you remember?
Nurse.
Nursemaid. Yes.
Nursemaid elbow.
Yes. Yes. Okay. So be familiar with different names of diagnose. Why? Because maybe, for example, they will change the name in the options. So you will choose a different name. Okay. So 4 years, refusing to move their right arm after sudden pull by mother. So this mechanism of injury is trauma or not non-trauma?
Non-traumatic.
Non-trauma.
Okay. So the arm is held in a slight flexion. So this diagnostic with pronation and adduction. So they can ask you by different way. In examination, which of the following signs or in inspection? So what do you think, guys? Flexion and
Pronation.
adduction.
Adduction.
So remember that. How to support your diagnosis? The patient is holding his arm in a slight flexion, not flexion, no, slight means mild. Pronation, they did not say hyperpronation, no, or full pronation, no, pronation. And adduction. So pronation here, down or palm down or up?
Down.
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 He has tenderness over radial head. This confirmed. So a slight flexion, pronation, adduction, it's a symptoms or signs?
Signs.
Symptoms or signs? Signs.
Yeah,
Okay.
science.
Yes. So it means a look. Tenderness, also sign. So tenderness here, it's a look, feel, or move.
Feel.
Feel.
Okay. So if they ask you in inspection, it means slight flexion, pronation, adduction. And if they ask you how to confirm that, you can check tenderness over which bone?
Radial
Radial
head.
head.
Radial head.
What is single most likely diagnosis?
Radial
Subluxation.
head subluxation.
Subluxation.
Excellent. Radial head subluxation. Okay. Did they said any feature for supracondylar fracture?
No.
Fracture? Dislocation? Why not elbow dislocation?
There is no significant trauma.
Yes. And the Monteja fracture. So any fracture, it's not accepted. Okay. So infants, young children, prone to subluxation of head of radius. Okay. So at the proximal radioulnar joint. So if they ask you, where is the problem? Proximal radioulnar joint. Remember that. Also, pull the elbow here. It can be nursemaid. Okay. So what about reduction, guys? How to reduce? So you will put some on which bone?
Radial head.
So here, this one slipped. It means radial head is outside, right? So you will put some here, and the patient will do. You have two techniques. You will put his hand in supination and then flex. Okay, you will put his hand in supination and then flex. So, number one, your thumb on which bone?
Radial head.
Radial head.
Okay. After that,
Supine.
after that, supination.
Forearm supination.
Supination
and flex.
Yes.
Flexion.
Okay. So the second technique, the opposite. The opposite here of supination. What do you think?
Pronation. Pronation.
The pronation and
Pronation or hyperpronation?
Hyperpronation.
Hyperpronation.
Already the patient in pronation, so you will do in hyper, right? If the patient his hand in pronation, is it logic to put in pronation or in hyperpronation?
Hyperpronation.
Hyperpronation.
Yes, remember that. Okay, so you will put some thumb on radial head, and after that, hand in hyperpronation, and then what? Flexion. Okay, it's easy. Okay. So reduction of subluxed radial head easily performed in the emergent department. Complication rate, two typical maneuver, supination and
Pronation.
using supination technique, the forearm is twisted or rotated outwards. Pronation technique, the forearm is twisted or rotated inwards. Okay. 4 years, refusing to move their right arm after sudden ball by mother. Arm is held in slight flexion, pronation, adduction. Tenderness over radial head. You make clinical diagnosis of pulled elbow. Which of the following damage as a result of pulled elbow?
Annular ligament.
Annular ligament.
Annular ligament, yes.
Okay. How to understand from X-ray? They give you X-ray only. They did not mention pulled elbow, or they did not mention slight flexion, pronation, adduction. There is no clue in the scenario. They did not mention tenderness over radial head. So how to understand from X-ray? How many lines?
2 lines.
Okay. So you are using these lines if subtle fracture or obvious fracture?
Subtle, not clear.
Yes,
not clear.
subtle fracture. Okay. So if they give you clear fracture like this, is this clear or not?
This is clear.
Displaced or not?
Yes.
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 But not complete displacement. Okay. Yes. Okay. So here, this X-ray with fracture or without fracture?
Without fracture.
Okay. How to know? So you can draw line parallel to the anterior humerus. So what is called this line?
Anterior humeral line.
Excellent. Anterior humeral line. So should transect what? Capitellum.
Yeah.
Okay. Should transect capitellum. If this line is away, so can you imagine here? If you draw line here, it's transecting the capitellum or away?
Away.
So this one, sure, fracture. Okay. Okay. The second line, what is called?
Radiocapitellar line.
Yes. Should transect?
The capital and برضه.
Yes. So it will be in the center of radius, should transect the capital. So we will see here. If you draw line here in the center of radius like that, okay, it will transect or not?
It will not.
Yes, transect.
It will.
Okay. So if anterior humeral line for which bone?
Humerus.
Okay.
Humerus.
And this one for which bone?
Radius.
So here, supracondylar fracture. What is the neurological injuries here?
Median nerve.
Yes. So the priority here, the common is median. If they give you option for anterior interosseous nerve, you can choose. Also, it can be ulnar, it can be radial. So if they remove the median, removed ulnar, you can choose radial. If they removed median, you can choose ulnar. So the priority for median, if they give you 3. And the management, any management for any fracture or dislocation, analgesia, neurovascular assessment before and after, back slap, also reduction if needs, breast elevation, and refer to orthopedic if needed. Okay, so here, 7-year, outstretched hand, X-ray, this one. What is the most likely to be damaged?
Posterior dislocation. Fracture, sorry.
I think he's asking type of fracture.
Yes, what anatomical structure likely to be damaged in this case? Yes,
Supracondylar.
diagnosis here.
Supracondylar fracture.
Okay, supracondylar fracture. Okay. Which anatomical structure is most likely to be damaged?
Median,
Median
number 1.
Brachial artery.
If they give you artery and the nerve, which one is important?
Artery more important.
Artery.
Yes, but here
Artery.
is it likely or important?
Likely.
Most likely.
Likely.
Okay, it means a common. It means artery also. Okay, so the most likely here artery and the most important artery. Okay.
Supracondylar.
Yes, supracondylar fracture most commonly occur in children. Usual mechanism is they can ask you about the mechanism, fall onto outstretched hand with elbow bent, distal fragment displaced, rotated backwards. Okay, so here other potential complication, median nerve, ulnar nerve, man union. Okay. Treatment here, manipulation under anesthesia with X-ray control, plus minus percutaneous scanning, followed by embolization, collar and the cuff for how many weeks, guys?
6 to 8.
Remember
6 to 8.
So if they give you supracondylar fracture and they ask you already manipulation done under anesthesia and the patient now X-ray done and no complication, you will observe the patient, admit the patient, or discharge the patient, or immobilization, collar and the cuff for 6 to 8 weeks.
Immobilization, collar and cuff for 6 to 8 weeks.
Yes, remember that. Okay. So these points very, very important for the Royal College. And this type of questions, decision making, what to do with the patient. Okay. It's very, very important for them. Okay. Now we will go for bones in the forearm. We are going from up to down now. So 12 years, girl, fall on outstretched right hand, jumping trampoline, obvious deformity, forearm, complaining of severe pain, sustained no other injuries. X-ray is shown below. So what do you think, guys?
Monteggia fracture.
Monteggia fracture.
Okay.
Monteggia fracture.
How to differentiate between Galeazzi and the Monteggia fracture?
Galeazzi radial.
Ulnar.
Galeazzi ulnar or radial? Or radial?
Radial.
radial. Montegia ulnar.
Okay, so the one fractured here, ulnar
Ulnar.
or
This is the ulnar.
Ulnar. Proximal ulnar.
Which one?
Montegia fracture.
Montegia fracture.
Montegia fracture. Okay. So Galeazzi for radius. Calls the fracture for radius or ulnar?
For wrist. Collis in wrist.
Radial.
Radius.
Radial is the wrist.
Radius, yes.
Yes.
Radial in
This
the
also
wrist.
in the wrist.
Radial in the wrist. Radial in the wrist.
Okay, so Galeazzi means radius, but it means in the shaft, right? Montegia in the shaft.
Of ulnar.
Regarding Coles, Smith, Barton in the wrist. Okay.
Yes.
Okay. Coles, it's anterior or posterior?
Anterior.
Collis anterior.
Anterior.
Posterior.
Anterior. Okay. Posterior or anterior?
Anterior Collis.
We will discuss now. It will be clear for you. But just remember, Coles, Smith, it's the opposite. And the Barton, what is the difference between Coles, Smith, and the Barton?
Barton double pathology. Radius and ulnar.
Okay, so I will give you the difference. Coles and Smith, horizontal fracture. Barton, it's vertical fracture. Clear?
Okay.
So Barton here, it's articular or not articular?
Barton not articular.
It means it's a vertical.
Got it.
The joint is fractured. Clear? Okay. So the patient has suffered of Montegia fracture, proximal third of ulna, associated with what?
Dislocation of the radial head.
Dislocation of radial head.
Remember that dislocation of radial head. Can you see?
Yes.
The radial head is dislocated. Should be
Dislocated.
here.
Far from position.
Yes. Okay. It's away from the center of the joint.
Yes.
So they can ask you in the exam. They can say this patient diagnosed with Montegia. What is the most likely associated feature? So dislocation of radial. Injury most commonly caused by, also they can ask you about the mechanism of injury. Fall on outstretched hand with forearm in excessive pronation. Child can sometimes be managed with manipulation, closed reduction, but adults generally require open reduction. So you have to check what in the scenario.
Age of the patient.
Age. When you are studying, guys, every point can be questioned. Take care. So here, once you see any, what is the type of fracture? Montegia. In Montegia, check the age. Check the age. If you find the age, children, you can do manipulation, closed reduction, but in adult, open reduction and
internal fixation.
Why?
Instability of the injury.
Excellent. Okay, we will go for Smith, Coles, Barton, Hutchinson fracture. Okay, be familiar with 4 fractures again. The most common in the exam, Smith and Coles. And Smith here because most people they think it's a Coles fracture and do back slap. And this patient needs ORIF. Smith fracture, most, not all. Most of them needs ORIF. That's why the Royal College care about this type of fracture. So, this one, horizontal or vertical?
Horizontal.
Can you see the article? Normal.
Yeah.
The curve is normal. Here, vertical or horizontal? The curve normal or
Horizontal.
Horizontal. This one horizontal or vertical?
Vertical.
Vertical.
The curve here disrupted, right?
Yes.
It means this one, any articular injury will cause bone marrow to go outside. Okay,
Yes.
easily. Okay, so this one is called
Barton.
Barton fracture. This one not horizontal. Can you see the joint line?
Yes.
Yes.
Normal. Not horizontal, not vertical. Only just this part. So what is the name?
Hutchinson.
Hutchinson's fracture.
Hutchinson.
Okay. So how to differentiate? I think we easily differentiate between 4 types. But here's the confusion. This one is Smith or Coles, right?
Yes.
Okay. How to differentiate between them?
Smith is anterior.
Anterior to
Coles-
what? Anterior to what? Okay. So if you will draw line in the mid line here, clear?
Right.
This hand anterior or posterior to the midline?
Anterior.
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 Clear?
Yes. Yes.
Can you draw line here? It will be
Yes, and the hand will be posterior to the line.
clear now?
Yes.
Okay. Okay. So this one is a fracture in the wrist or in the shaft?
In the shaft.
Yeah.
So shaft, you can think about 2 fracture.
Montega or Galeazzi.
Montage and Galaxy.
This one ulna or radius?
Radius.
Radius. So which one?
Galeazzi.
Galaxy fracture.
Galeazzi fracture.
Galeazzi fracture. It's associated with
Ulnar
Dislocation.
Ulnar head dislocation.
radioulnar joint. Okay. So here they can ask you about the diagnosis. They can ask you about the injury also. So neurovascular injury. What does it mean, neurovascular?
Nerve or
Nerve
artery.
and vessel, blood vessel.
vessels.
Nerve and vessel. So radial artery, anterior osseous nerve, and radial nerve as well. Okay. Also, the management will be same. Non-major trauma, all same. Give the patient painkiller, reduce, assessment before and after, X-ray before and after. After that, you can do back slap. After that, if need arm and
Refer.
you can do. After that, you check disposition. This patient needs admission or discharge, follow up. If follow up, within how many weeks, and so on. Be familiar with this thing. So here, be familiar with radioulnar joint
dislocation.
Okay, 12 years. 12 years. Outstretched right hand after falling scooter. Obvious deformity. Severe pain. No other injury. What is the injury here?
Anterior Galaxy.
Galeazzi fracture.
Galeazzi. Which injury?
Anterior
Radial.
interosseous.
Anterior interosseous.
Interosseous first.
Yes. Okay. So the patient here, Galeazzi fracture. Okay. The most common damage nerve, anterior interosseous nerve. This one motor or sensory?
Motor. Purely motor.
Motor. Okay. So purely motor branch of median nerve, often overlooked as there will be no sensory deficit. Why? Why they did not say median nerve? Because the patient has no problem in sensation. That's why you have to check for what?
For movement. Motor.
For motor. Okay. Treatment. What is the treatment here in this?
Over reduction and internal fixation.
Reduction and internal fixation.
Orif. So in Galeazzi, what is the management?
Orif.
In Montegia?
According to the patient age.
Child.
Yeah.
According to the age. If young.
Young neurovascular assessment rates the reduction.
Okay.
If young, open reduction.
If young, no. If adult,
no, it's adult open reduction.
If adult or if young, you can do manipulation and you can do closed
close
reduction.
reduction.
Okay.
Yes.
So it's a different, guys. Okay. 60-year painful swollen deformed left arm, couple of weeks ago, as pain swelling not improving. So X-ray is showing this one. So what is the abnormality here?
Callus formation.
Yes, callus formation. Okay. So why here it's not improving?
Because no alignment.
Reduction.
Okay.
It's not reduced.
According to the X-ray, malalignment.
No alignment.
Okay. Also, in general, it can be infection. It can be tissue between bones. Also, maybe no splint. The patient is moving his arm. Okay. 57, lady, fall on outstretched hand, ice skating, painful swollen, deformed left wrist. X-ray shown below. What do you think? If we will, you will depend on this view or this view, lateral view?
Lateral view.
Lateral view.
Okay. So here, this bulb or dorsum, this one?
Palm.
Okay. So if you draw line in the midline here, like that. What do you think?
The hand is anterior.
Anterior.
So it's a Smith fracture.
Smith fracture.
Collis
fracture.
Posterior.
Collis fracture.
The hand is posterior.
Posterior to the anatomical position. The palm is mid.
Is this one posterior or anterior? If you midline here.
Posterior.
Posterior. Okay. So the patient has caused the fracture. I will show you now a Smith fracture. This one. If you draw line here. Okay. So posterior or anterior?
Posterior.
Okay.
Posterior.
Yes.
Posterior.
So
this is posterior and Collis.
Yes. So I will show you now a Smith fracture. It will be obvious. So call the fracture of distal radius within 2.5 centimeter of lower end of radius. Dorsal displacement. What does it mean, dorsal?
Posterior displacement.
Posterior displacement of which segment or fragment?
Distal
segment.
Okay. They can ask you about the mechanism of injury. So also the management. So manipulation and reduction indicated if any of the following. So they can ask you by two ways. What are the indications to do manipulation and reduction? So if you find 10 degree of posterior tilt of the joint on lateral view, okay. If you find displacement of ulnar styloid, so how many degree here? If you've more than 10, right?
Yes.
Okay. So 10 degree of posterior tilt of joint line, displacement of ulnar styloid, marked ulnar angulation distal fragment, readily appreciated naked eye deformity. It means from an inspection, it's obvious. Okay. Like what obvious? This one, right?
Yes.
Obvious. So this one, which fracture?
Collis.
Collis fracture.
Collis fracture.
Okay. This one, if you will draw with here, line here.
Anterior.
It's obvious here.
Smith.
Okay.
Anterior Smith fracture.
Yes. Obvious?
Yes.
Okay.
Yes.
So if you will draw with line here, it means it's anterior. Okay. So this one Volar means anterior displacement of distal fragment. This fracture also directly flow to the dorsal forearm or fall on flexed wrists. Be familiar with that. Why also? They can mention that, guys, in the scenario. Okay.
Text or asterisk.
So sometimes they are mentioning in the scenario. Okay. Indication for open reduction. Regarding Colza fracture, they mention only manipulation and reduction. Did they mention here ORIF?
No.
No.
Okay. So
No.
yes, that's why Smith fracture. It's important and common in the exam because some people they will think it's Colza fracture, and 1 mark it's enough to pass. Be familiar with that. Indication for open reduction ORIF in Smith or Colza fracture.
Smith.
Inability to adequate reduction. It means you try to reduce, you cannot. Number 2, fracture line crossing into dorsal articular surface. It means Smith type.
Type 2.
Yeah.
Fracture involving radiocarpal joint. It means the type 3.
3.
Otherwise, it will be type.
Type 2.
No, I said otherwise. Other than 2 and 3, it will be type.
It will be type 1.
Type 1.
Okay. So type 1, it will. What is the action?
Close reduction.
Close reduction.
Manipulation.
If inability.
Inability to obtain adequate reduction, we will go for ORIF.
ORIF.
Clear now?
Yes.
So I think is this one very obvious. So if you draw line here.
Smith.
Yes.
So the palm, right? The palm. And this is the dorsum, right?
Yeah.
Okay, so if you draw line here, it's anterior or posterior?
Anterior.
Anterior.
So the fracture is?
Smith.
Clear?
Yes.
Okay. This one, can you see the fracture here?
Part 1. Vertical fracture.
Clear now?
Yes. Clear now.
Yeah. Okay, so intra-articular fracture of distal radius. Okay. What is the management?
ORIF.
Open reduction.
ORIF, really?
ORIF. Because what?
Because intra-articular.
Yeah. Excellent. So if they ask you what is the management, ORIF. If they ask you why this patient needs ORIF, so because it's intra-articular. Okay. And also the mechanism of injury. So fall onto extended and pronated wrist. What is the type of action? Stable or unstable?
Unstable.
If patient needs ORIF, it's unstable. Okay. We finished the shoulder, elbow, forearm, and now we will go for wrist. Okay. So what do you think the fracture here?
Scaphoid fracture.
Scaphoid. Excellent.
Scaphoid.
Yes, it's very obvious. Okay. Regarding scaphoid, it's very, very important in the exam. So here can be clearly seen in the X-ray, like this question. Also, sometimes it's not clear. What to do if clear? What to do if not clear? If they give you scenario like that or scenario like that, we will see. First of all, the investigation of a choice is.
They
ask you what is the investigation of a choice. You can choose plane radiograph. Dedicated scaphoid views. So here, scaphoid views important. Should be written. What are the views? It can be question. So BA, oblique, lateral, angle BA. How many views, guys?
4.
BA, oblique, lateral.
posterior anterior, angled posterior anterior, oblique and lateral. Initial radiograph can miss 20%, so it's not good.
Yeah.
Not good. So in the acute setting of a scaphoid fracture is clinically suspected. What does it mean clinically suspected, guys?
With presentation.
By examination also.
Excellent.
Presentation and examination.
Without X-ray yet. Without X-ray. So the patient has mechanism of injury. He said fall onto
Outstretched hand.
Outstretched hand.
From history, you ask the patient what happened. He will say, I fall on outstretched hand. Okay? And hyperextension of the wrist. So suspected what?
Scaphoid fracture.
Yes. And after that, you examine the patient. The patient has tenderness over the bone scaphoid.
Scaphoid.
Okay. You did the X-ray. The X-ray is normal. No fracture seen. What to do?
Follow up.
Follow up.
How many days?
10
10 to
days.
14 days.
10 to 14 days.
If the patient improved, no pain, and is moving, everything is okay. So no need to do anything. If the patient after 10 to 14 days, he's complaining, worsening, or the same problem, suggest what?
MRI.
MRI.
So they can give you another question. Patient after 10 to 14 days, he came with worsening. What is the next action? So you will choose MRI. Okay.
Yes.
Yeah. So when you are studying any guidelines, any question can be point. Okay. So here regarding alternative, if it's not available. So if they said in the scenario, MRI not available, what is the next action?
CT.
CT.
Scan.
Scintigraphy bone scan. Is it available in ER? No.
No.
So don't choose, okay? The patient wrist should be embolized in which cast?
Collis.
Collis cast.
Collis cast or?
Wrist splint.
Until this can be performed. So if they said in the exam, the patient is waiting for scintigraphy bone scan, what is the next action?
Collis cast.
Collis cast.
Because it's not available, right?
Mm.
So the patient wrist should be immobilized and Collis cast or wrist splint. If the patient is waiting for 10 to 14 days for follow-up, you can do
Collis cast.
or
Wrist splint.
splint.
Wrist splint.
Yes. Okay. Because if you ask him for discharge, you have to splint, right?
Yes.
The blood supply to scaphoid bone supplied by lateral and distal branches of what? Which artery?
Radial.
Radial artery.
So what is the most common complication here in scaphoid?
Vascular necrosis.
Vascular necrosis. Why? Because supplied by?
Blood flow.
By the radial
Lateral and
lateral
distal
branch.
branches of radial artery.
Okay, excellent. So it's retrograde, not antegrade. Okay. Here, what is the most appropriate initial management?
Immobilize in wrist splint.
Okay. So he said here, 35-year-old man suffered fall from outstretched hand. So it's mechanism of injury, confirming the mechanism of injury, and he has tenderness in anatomical aspects. Okay. So if I ask you in another question, this patient suspected scaphoid fracture. What examination you will do?
Tenderness in the snuff box.
Clear?
Yes.
Okay. So if they said the patient has tenderness, it means suspected scaphoid without X-ray. I did not do X-ray yet. Okay. So he has tenderness. It's confirmed or suspected?
Suspected.
X-ray confirmed or suspected?
Confirmed now.
X-ray confirmed.
Okay. So if they give you this one, whatever, X-ray normal or abnormal, what is the action?
Immobilization.
Immobilize the
And
wrist.
follow-up intervals.
And follow-up
Plan and
intervals.
follow-up intervals.
Suspected or confirmed, it means immobilize and wrist splint. But if he said the patient has pain in his hand and X-ray normal, it's not suspected here, right?
Yes.
You should find out stretched hand, and you should find what?
Pain and the
Anatomical
tenderness
st-
in anatomical
anatomical
symptoms.
You suspect, and now you confirm. Okay. So what is the most appropriate initial management? Excellent, guys. So
Immobilize.
guys, and rest splint and follow up in 10 days. Okay. 22, scaphoid review clinic. 2 weeks ago, suffered fall on outstretched left hand. Initial X-ray was normal. That's why he is following up with scaphoid review clinic, right? She has been immobilized, so she came to you, for example, and you immobilized and rest splint and ask her to follow up. Today, she continues to have tenderness and left anatomical snuff box. What does it mean? Today, she have tenderness.
Suspected
Didn't
scaphoid
improve
fracture.
after 2 weeks.
It means they're not improving, right?
Yes.
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 Okay, what is the choice of
MRI scan of the
MRI scan of the wrist.
Okay. If MRI not available,
CT scan of the wrist.
CT scan. Okay. If CT scan
Cystography.
Bone scan.
bone scan, and if the patient will do bone scan, what to do?
Immobilizing the wrist splint.
Immobilization. Okay. If the patient
There is an option.
Yeah.
Excuse me, doc. There is an option if the MRI is not available. There is an option for the repeat of the X-ray and CT. Both of them are found if you go back to the slides for the modalities. I think there is a repeat radiographs, CT scans, and scintigraphy. So we have 3 options here if MRI is not available.
Yes,
we can repeat the radiographs.
Okay, and the alternative include repeat radiograph, CT
scan, and scintigraphy.
Yeah.
So we have 3 alternatives here. Am I right?
Yes. Here regarding repeat radiograph, did they mention here repeat?
No.
They say the scaphoid view. If MRI is not available, can I choose scaphoid view X-rays or CT scan? Because both of them.
They did not say repeat here.
So directly I have to go for CT scan.
Yes.
Okay, thank you.
Here, scaphoid view, it means it's like the first time. Okay, so you can go for CT scan. Sorry, MRI. Here, if they said MRI not available, you can go for CT scan.
Okay, thank you.
If they put in the options repeat X-ray.
If they said MRI, if they said MRI not available, and you have option for repeat X-ray, you have option for CT scan, according to their guidelines, so you can repeat X-ray, repeat radiograph, because they mentioned repeat radiography first, right?
Yes.
Okay. Yeah. Okay.
Yes. Okay.
So anything you mention first, it means the priority. Certified, fall on outstretched hand, same anatomical snuff box, and I think it's clear here. So the most likely mechanism of this injury. What do you think, guys?
A.
Fall on hand, wrist dorsiflexed, and radially deviated. Remember that.
It means that the wrist is overextended.
Okay, we finished this one. We will go to the distal. Distal here, it means we are talking about carpal bones. So leonate and perileonate. If the normal, you will find this one radius or ulna.
This one
Radius.
ulna. Radius.
This is a radius.
The big one is the radius here.
Radius, okay. And this one, which bone?
Lunate.
This is leonate.
Excellent. And after that?
First that is a proximal phalanx.
So if you find all in the same alignment, so this one is dorsal and this one is
volar.
So in the X-ray, in the exam, check the dorsal surface and volar surface. Okay, so which is important for you, the dorsal or the volar?
The volar. The volar for the leonate dislocation.
Both. So check. You can draw which line? One or two?
Two lines.
Two lines. You have two lines. So dorsal and volar, both of them important. Okay. So if you draw two lines, if you find nothing outside the lines, it means normal, right? If you find only leonate outside the line, it will be
Lunate
dislocation.
Okay. If you find perilunate dislocation, what does it mean?
Perilunate dislocation.
Peri, it means around, the bones around leonate. It means the leonate, it's not dislocated, right?
Yeah.
Peri, it means bones around leonate, but leonate not dislocated. So it's called perilunate dislocation. Clear?
Clear.
So if you find volar, it means
leonate.
Find the dorsal, it means
perilunate.
And this one will be cup, the same curve like that. Okay, if you find the cup in the same place, it means it's normal. Okay, we will see. So here in this X-ray, okay, what do you think? If you draw line here and the line here, okay.
Volar.
Leonate. Okay. So we will go back. So can you see the cup? Can you see this border?
Yes.
Can you see this border? Okay. So should be this one here, not here. Okay. And what about the dorsal border? Normal?
No.
Yes. Okay. So all bones, these bones, normal. Okay. So this patient has leonate dislocation, and regarding leonate dislocation, occur as a result fall on outstretched hand also, with the rest is forceful dorsiflexion. Remember that. Result of high energy trauma, such as fall from height or motorcycle accident. Rest is very painful. Prominent volar swelling, palpable mass. Patient often holds their fingers in partial flexion due to pain caused by extension. So remember that they can ask you how to confirm that. Okay, the swelling often result in acute carpal tunnel syndrome. If they ask you about the complication, what is the complication here? So which nerve?
Median nerve. Median nerve.
So if they ask you regarding this one, what is the nerve injured?
Median nerve.
Okay. Lateral view. Okay, so you will depend on the lateral. If they ask you which view is better,
lateral view.
Lateral view.
Yes. So lateral view radiograph of the wrist will show the leonate post of the radius in volar direction. Okay. So if they ask you what is the abnormality here, so the leonate here is post volar or dorsal?
Volar.
Volar.
Okay. Urgent management. Here the management important in any orthopedic, in any non-major trauma or trauma. So urgent management necessary with reduction, surgical repair. So what is the management here?
Reduction and surgical repair.
Yes, of disrupted ligament to prevent long-term joint dysfunction. Despite treatment, there remains a very high risk for future degenerative arthritis. So what is the complication, long-term complication?
Degenerative arthritis. And wrist instability.
We can give you another question. Leonate dislocation, not confused with perileonate dislocation. Okay. So we will see the other one. Okay. Okay. This.
You're asking about the mechanism.
Yes. What is the mechanism for this injury? I think it's the same X-ray.
Yes. Leonate dislocation.
It's fall onto hand with the wrist dorsiflexed.
Excellent. Okay. Same X-ray. Which nerve is most likely damaged?
Median nerve.
Median nerve.
Excellent. Okay. Now the cup in the same alignment, right?
Yeah.
It's very obvious here.
Perileonate.
Yeah.
What about other bones? If you draw line here and the line
Will
here,
be dorsal
displacement.
dorsal, so perileonate dislocation.
Clear?
Yes.
Yes.
So if you draw line here like that, and you draw line here like that, so here is a leonate bone in place, right?
Yes.
But bury the bones around the leonate displaced posterior or anterior?
Posterior, dorsal side.
Posterior.
Because this is the dorsal, right?
Yeah.
Okay, so it's perileonate dislocation. Okay. Which nerve most likely to be damaged? Perileonate.
Also median nerve.
Median.
Also median nerve. Excellent. Okay. Most likely mechanism of injury. What do you think?
Second option, fall into hand with the wrist roller.
Dorsiflex and ulnary deviated. Dorsiflex, ulnary deviated. What about the other one? They said dorsiflex. Okay. So fall onto the wrist, dorsiflex, and ulnar deviated. So perileonate. Okay. So here dislocation of carpus relative to the leonate. Relative. It means the bones around what?
Around the leonate.
Leonate. Okay. Should be with the same normal alignment with distal radius. This wrist injuries can easily be missed on radiograph. Yes. Leonate or perileonate can be missed. What do you think?
Leonate, I think.
The leonate can be missed or perileonate?
Perileonate.
Perileonate. Because if you see leonate in the same alignment, you will miss. Okay? But this one, leonate, it's easy to catch. Okay? That's what perileonate, it's This bone should be here, right? This curve should be with this curve, right? Brilliant. Okay. What about the management?
So what if?
Damage to median nerve as a result of injury, arterial compromise, or compartment syndrome. What about the complication in neonate?
Carpal tunnel syndrome.
Carpal tunnel syndrome. And what else in long-term management, long-term complication?
Degenerative arthritis.
Arthritis, okay. But this one?
Arterial compromise.
Arterial compromise.
Avascular necrosis and compartment syndrome.
Okay. Which eponymous is visible? Eponymous, it means the name of the sign of maybe fracture or dislocation or whatever. So eponymous here is the name of the sign. What do you think, you guys?
Thierry-Thomas sign.
Yes, excellent. So can you see the gap here? Very obvious. The distance between them, very obvious. Okay. So another question, what is the most likely diagnosis? Same.
Yeah.
Lunate dislocation.
So here, Thierry-Thomas sign, it means dislocation between which bones?
Leonate and scaphoid.
Scaphoid and
Scaphoid and lunate.
So what is the option here?
Scapholunate.
Scapholunate dissociation.
Yes, scapholunate dissociation. Okay. What's the most likely mechanism of this injury?
Fall on hand with wrist volar flex.
Okay, fall on hand, wrist, dorsiflex. Okay, so here the most important to understand the management and the complication. Okay, so here the result separation between scaphoid and the leonate bones, space in the X-ray, as we said, gap. That's why it's called Thierry-Thomas. This one person, if you write in Google Thierry-Thomas, you find the picture of him. Okay. Also sometimes referred as David Letterman sign. Remember this one because maybe in the exams they will give you this name. Okay. Or Madonna sign. So injury most commonly occur, fall onto outstretched hand, wrist dorsiflex. Clinical features, pain, swelling, or radial side of wrist. Remember that. What is the tenderness in scaphoid? Scaphoid, what is the location?
Snuff box.
Snuff box. Snuff box. Anatomical snuff box.
Yes. Okay. This one in pain, swelling, radial side of wrist, and a clicking or clanking sensation that occur with wrist movement. If left untreated, what is the complication? So capitate will migrate proximally between scaphoid and the leonate. Okay. This will result in severe degenerative disease. It's called slack wrist. Slack, it means scapholeonate advanced collapse. What is the complication, guys?
Slack wrist.
Slack wrist.
Okay, so which complication most likely to occur?
Slack wrist.
Okay, so what does it mean, slack wrist? The capitate, it will go between scaphoid and
leonate.
It will cause degenerative
Scaffold unit.
Advanced collapse. Okay.
Collapse.
Okay. Can you see?
Yes.
Yes.
What is the most appropriate initial management? So what is the problem first? What is the problem here? Can you see any abnormality in the X-ray? Any obvious abnormality?
Dislocation in one of the carpal bones.
If you don't see anything, for example, so you can read the scenario: fall onto outstretched hand. What does it mean? Maybe scaphoid, maybe other abnormality, right? Okay. So tenderness over scaphoid tubercle. What does it mean?
Maybe
Scaphoid
fracture or
Position of the scaphoid fracture.
So it's suspected or confirmed current scenario?
Suspected.
Suspected.
Do you need the X-ray?
Yeah.
Yes.
Yes, you need the X-ray. But do you think the management here, if not obvious, do you need that?
Immobilize.
Second option,
Yes, we need
immobilization,
monitoring.
brace treatment and follow up in 10 days.
Because you have what?
Because they have pain in the
Tenderness.
anatomical.
Tenderness of the scaphoid tubercle.
Yes. If you don't have tenderness here and the X-ray is not obvious, so no need to do anything, right?
Yes.
Patient immobilized in wrist splint and follow up in 10 days in scaphoid review clinic. Okay. Okay. This one, it's not common in the exam, but it can be triangular fibrocartilage complex, TFCC. What does it mean? This one. Can you see? Between which bones?
In radial and ulnar.
Radius and
Radial ulnar trunk.
So here they can ask you regarding injuries it may cause. Which sign?
Piano key.
Yeah. Piano key. What does it mean? So this tubercle radius or ulna?
ulnar.
Ulnar tubercle. Ulnar.
Okay.
It's ulnar tubercle.
If you push this one, it will go.
Towards the radial.
Yes, it will go down, right?
Yes.
Okay, this is called piano sign. So the ulnar tubercle, it will be raised. So this sign of which problem? Injury.
TFCC. Triangular
complex.
fibrocartilage complex.
Yes. Okay. So how to understand that? You will find the ulnar tubercle raised. Okay. And what does it mean? Piano sign positive. Press on.
Ulnar tubercle.
It will be down.
Move down.
Like you are pressing on piano. Okay. Yeah.
Okay.
If you remove your hand, it will be up again. So you can press up and down. Okay. Okay. So the last one here, mallet finger. Be familiar with that. They can ask you about mallet finger, and also they can ask you about mallet splint. So this tendon is tensor or flexor? It means dorsal or volar?
Extensor.
Extensor. Okay, so they can ask you about the device. They can ask you also about the cause and the mechanism. So bony or tendinous disruption of extensor tendon distal to DIB joint, and also another mechanism, hyperflexion. And they can ask you regarding indication when to do surgery. So if large fracture fragment, if volar subluxation of distal phalanx, volar, okay, so like this one, okay, and also damage tendon. And if failed, what does it mean? The failed non-surgical treatment. You give the patient mallet splint but not responding. So it means failed non-surgical treatment. So what is the single most likely diagnosis?
Mallet
Mallet.
finger.
Mallet finger.
Okay, excellent. So be familiar with mallet finger and the mallet splint. Anatomical structure has been damaged.
Extensor restore.
Yes, extensor digital. Okay. Regarding Salter Harris, it's a common question in all exams. I'm talking about MRChem SPA and FRChem SPA. Okay. The most common type of Salter Harris fracture.
Type 3.
Most common.
Type 2.
Yes, type 2. Excellent. So here, type 2, how much?
75%.
75%.
75%. Okay. So regarding classification, most common in the exam, type 3. Most common question, not Salter Harris in general. No, I'm talking about the exam. Most type asked in the exam, type 3. Clear, guys? So you can find in the exam this one. Okay. So if they ask you what is the most common type, type 2. Don't, if they give you X-ray for type 3 and ask you most common type, what is the answer?
Type 2.
Type 2.
Yes, take care, they are playing with words. Okay. So if they give you X-ray, for example, they said here in fracture involving gross plate of proximal phalanx of his left middle finger. So which type here regarding the scenario, not the question. I'm talking about the scenario.
Type 1.
Yes,
It's type 1. Type 1. Type 1.
Gross plate, okay, of proximal phalanx of his left middle finger. So gross plate here, it means the type 1. Also, gross plate, it means the type 5, right? But he did not say compressed. Okay. So type 1 here, it means only involving of gross plate. So what is the difference between them? Salter, it means S straight across. It means straight across the gross plate, this gross plate, the green one. A, above. Okay. So if you find in the exam fracture above the line, the horizontal line, it means type
2.
If you find L lower, okay, that's why they call Salter Harris. So L, it means below
Lower.
the line, the gross plate. If you find the throw, it means all layers, above and lower. It means to or throw, okay? It means type
4.
4. And if you find it's not clear in the exam, if you find it's not clear in the exam, the X-ray is not obvious in the exam, which type?
5.
Clear? This happened in FRChem SPA. They give them type 5. And people, they said it's not clear, the zoom not good. The problem not in the zoom, guys. The problem it's a type
5.
Yes, type 5. Why? Because fracture and compressed. It means the fracture not obvious. Okay. So take care.
How we'll differentiate it from normal ones?
Yes, I will send you the image came in the exam.
Okay, sir.
Okay.
Yeah, I will send in the group, inshallah. Okay, guys, thank you. Inshallah, next time we will discuss lower body. We finished the upper body, non-major trauma. We will go for lower body, including also tetanus prophylaxis and wound treatment and bites. Bites here, it means human, animal,
including rabies and snake bite. Clear, guys?
Inshallah.
Oh,
Okay, inshallah.
thank you,
Thank
Dr.
you,
Hani.
thank you,
so
thank
much.
you, thank you, Doc.
Thank you, sir.
So much.
I will.
Thank you, Dr. Hani.
I will make decision. It will be one session per week. So I will be free for discussion for questions in the group. Okay. I will try to make at least 10 questions per day. I'm talking about recalls, and I will focus